Now I would like to invite Dr. Sanjeev Saigal to give an inaugural note and invite Dr. Sanjeev.
Uh, Thank you very much. It's my great privilege to invite for this inaugural address Professor Josh Levitsky, who has been kind enough to join live from US, and he's going to speak on tolerance in liver transplant current status, something which is a dream for all hepatology surgeons. And this is going to be a state of art inaugural address. Just to briefly mention, he's the director of liver research in Northwestern University, Feinberg School of Medicine, Chicago. He's a great researcher, has been trained in Michigan, MD from Albert Einstein, has been trained in Chicago Hospital in internal medicine residency, transplant hepatology fellowship at University of Nebraska. He's a certified American Board of Internal Medicine and Gastroenterology and Transplant Hepatology. Dr. Levitsky's academic interests are clinical and transitional in nature, with a focus on liver transplant immunosuppression, tolerance, and biomarkers. He's the deputy editor of American Journal of Transplantation with numerous peer-reviewed journals, abstracts, and so on. Principal investigator and co-investigator of various NIH and pharmaceutical investigator-initiated trials. One of the passions of Dr. Levitsky is trainee education, establishing the AST comprehensive training curriculum, and regularly participating in the yearly Fellows Symposium. So with these words, I would invite Professor Levitsky to give this inaugural address, and we welcome you once again, Professor Levitsky.
Everybody can see everything okay?
Yes, it is.
Okay, great, thank you. It is 8 in the morning here in cold Chicago. It's about 30 degrees Fahrenheit here. I'm sure it's a lot warmer where you are at. But nevertheless, I'm very excited to be here to give this prestigious address to you all to discuss the current status of liver transplant tolerance. So I wanted to start with just a kind of a definition, because when you say tolerance, it can mean something a little bit different to everybody, but I'd like to kind of give a definition that is used really in the literature called spontaneous or operational tolerance. And this is essentially a state where an organ transplant recipient, without any specific immunosuppression treatment or without any treatment, has normal allograft function in the complete absence of immunosuppression. So this means either the patient stopped immunosuppression themselves, or they were withdrawn from it by their provider, and there wasn't any specific treatment to modulate the immune system. This is in contrast to experimental tolerance that really needs to be proven, which is absence of donor-specific immune responses, but intact immunity to third party, such as what we're all dealing with these days would be COVID vaccination. They respond well to that, but they don't reject the donor. And there have been multiple single center experiences in the 1990s, and we've all had a few cases here and there of patients who stopped immunosuppression on their own, or had a contraindication or had a deliberate supervised withdrawal, usually in the setting of something like PTLD or metastatic cancer. And we know as the later you get from transplant, the more likely you are to be successful with immunosuppression withdrawal, just from simply taking it off. But this takes significant time to emerge. This rarely occurs within the first 5 years. And thus biomarkers or tissue biomarkers would be very helpful in identifying these patients much earlier. The largest experience, although not very large in terms of the whole population, is in kidney transplantation, which up to about 200 patients have been reported to have discontinued immunosuppression or needed to for some reason. And what scientifically is seen as been a distinct peripheral blood immunophenotypic or transcriptional profile related to B cell signatures and Tregs. The problem with these studies is that these are kind of patients that just sort of stopped on their own. We don't have any predictive signatures before they withdraw immunosuppression. There's lack of appropriate controls, lack of histological demonstration of normal or quiescent grafts. In a lot of these studies, they didn't even do biopsies. They just had normal kidney function. And there's some evidence that these patients lose tolerance over time. So interesting, but probably not clinically applicable. So why should we pursue tolerance in liver transplant? Why even think about taking patients, really minimize or off immunosuppression? Well, I think you all know that immunosuppression contributes to detrimental long-term consequences in liver transplant patients. It's not the only factor, but it's a big factor in contributing to the causes of death, including cardiovascular, infection, malignancy, and kidney dysfunction. And we know that with just withdrawal of CNI, when successful, and there have been some studies with not fully withdrawing immunosuppression, but just withdrawing calcineurin inhibitors, that there's perhaps a reduction in cardiovascular and cancer mortality and better GFR in patients who are withdrawn off immunosuppression versus those who remain. In addition, do patients want to do this? We surveyed our patients at Northwestern, and a good percentage of them, you would think that most of them would be fearful of stopping immunosuppression, but over a third of patients desire to attempt to withdraw immunosuppression because of various reasons. And we know that in pediatrics, Sandy Feng has studied that patients pediatric participants who withdrew immunosuppression had improved disease-specific quality of life. And those who developed rejection with withdrawal did not have a detriment overall to quality of life, meaning it was easily treatable and it didn't impact them. The other reason for why to consider liver transplant is liver has the highest rate of spontaneous tolerance. And there are a number of mechanisms that I don't have the time to go into, but they include immunological mechanisms and what we see in the clinical space, which is while rejection is an important endpoint, there's less relevance in liver compared to other organs. It's much less common to see chronic rejection, particularly in a compliant patient, lower immunosuppression required. I heard on the previous session discussion about liver plus other organ. Certainly, I agree that the liver can generally protect the other organs from rejection and less significance of HLA matching. So here I've summarized, and sorry, this is a little bit, actually this should be 2021 because I updated it. Just basically all of the studies of immunosuppression withdrawal in liver transplant that have been reported up to date. And rather than looking at specifically all of these studies, just to summarize, most of these have been single center adult patients, mostly DDLT, mostly calcineurin inhibitor withdrawal, mostly later after transplant. And the success range is very variable. But it's really the point I want to drive home is that the success rate, if you consider the entire liver transplant population, is very, very small. So whenever you see we have a 40% success rate, 60%, you have to look at the trial itself and realize these were very, very select patients being withdrawn off immunosuppression. So I wanted to go through a few of these just to discuss some messages that have come from the trials that have guided sort of the pathway forward. This was sort of the first key trial almost 10 years ago of pediatric living donor liver transplant recipients from a parental living donor. And more than 4 years after transplant, this was a simple weaning. Again, if you look at the top, 129 screened, but only 20 initiated withdrawal. So a smaller percentage, and 12 achieved tolerance. So really, we should be looking at 12 out of 129 than 12 out of 20. But one of the themes is that the longer time from transplant, the older the age at study entry, and on an entry biopsy, the absence of portal inflammation was predictive of success. Dr. Feng did a larger study, somewhat similar to the initial WHISPER study, a larger number of patients, a little bit lower tolerance rate. And what they found similarly, basically the same thing: older age, longer time from transplant, absent portal inflammation. We'll see this in adults when we come to this also when I discuss the adult studies. One of the things that this study was really nice to do was that they dove into some of the biomarkers that at entry biopsy may be able to predict the outcome. So one thing that we do know is that DSA, having a class 2 DSA at baseline or developing de novo can be predictive of future failure. Same thing with this inflammation, but also very interestingly, the pairings of antigen presenting cells and T cells within the biopsy itself. So more pairings mean more immunological recognition were significantly higher. On the bottom right, you can see here in the future non-tolerant patients. So if you see this on a biopsy entry, again, this is not very commonly done. It was done retrospectively, but this is something to look at as a marker. More pairings on a biopsy, less chance of tolerance. Moving to the adult studies, this was a published study that we participated in called AWISH. This actually enrolled patients much earlier after transplant, 1 to 2 years, who were on monotherapy immunosuppression. The difficulty with this study included a lot of Hep C patients that they had to stop the study. This was done about 10 or 11 years ago. But the success rate was very low, 13%, and much lower if you consider the whole 275 enrolled. The key thing is that a lot of patients were able to minimize immunosuppression, but if you push that minimization towards full withdrawal, patients develop rejection in the majority, and de novo DSA predicted that withdrawal attempt or failure of withdrawal attempt. The RISET consortium, centered out of Barcelona, from Alberto Sanchez Fuego, who moved to London, did something similar. They took patients who were further out from transplant, and it had a higher success rate. And what they did find, again, years from transplant, age at transplant, predicted immunosuppression success. And what they found was a gene expression signature on the biopsy that seemed to predict the success of tolerance of iron homeostasis. The issue, as you can see, is that the longer you are out from transplant and the older you are, the more successful you will be. But then the clinical benefit becomes of significant question. To withdraw somebody, 10 years from the transplant, are we going to have any benefit for them clinically, rather than doing it earlier, where we all believe that benefit would be higher, but the chance of success is lower. I wanted to talk a little bit about our mTOR inhibitor interest, which we know immunologically, and we've seen this in our laboratory and other laboratories, that mTOR inhibitors such as sirolimus and everolimus promote immunological tolerance. They don't block the pathways like IL-2 production that are important for regulatory T cells to generate tolerance. And so we've had an interest in this conversion to mTOR inhibitors as a pathway towards tolerance. An initial study we performed showed that the conversion from TAC to sirolimus led to a stimulation of Tregs in the blood and the bone marrow, and also regulatory dendritic cells, and also in the biopsy here, FOXP3 is a marker of Tregs, and you can see them increase with the conversion, direct conversion. So we took this further and withdrew patients, a small study from sirolimus, and just a very similar study, had 8 out of 15 patients become successful with weaning. And what we found was that these tolerogenic dendritic cells, and to some degree Tregs, but also the cells that are involved in sort of immunological senescence, predicted tolerance. We also tested the RISET biopsy gene expression signature, and that also predicted tolerance. These are small studies, but they are proof of principle. I wanted to mention the interest in developing cell therapies for induction of operational tolerance. And this is, again, a sort of an immune manipulation to help expand, give patients regulatory T cells. These were donor-specific Tregs, a small study, but they were able to, at 1 year, which is pretty impressive, get 7 out of 10 patients off immunosuppression therapy. and 3 of them had rejection, had autoimmune hepatitis, so probably not the best population. Sanchez-Fueyo's group in London and in Barcelona just showed the regulatory T-cell therapy that is even more specific, can be safely infused in patient populations. So just the published trials have shown that highly select recipients monitored in prospective studies could have a reasonably high chance of withdrawal. Biopsies before and after withdrawal are really important to identify candidates who shouldn't be withdrawn and also confirm tolerance after. Early after transplant really requires some type of immunological manipulation, perhaps a switch to an mTOR inhibitor, some type of immune regulatory boost like Tregs or mesenchymal stem cells or dendritic cells. Later after transplant, it might be safe to simply slowly withdraw, but may lack clinical benefit. And these are the markers that I mentioned that we've looked at. Where are we going forward? There's a study taking patients further out from transplant, looking at a signature of immune exhaustion. Again, a small percentage tolerant. Same thing with the LIFT group by Sanchez-Fueyo, a group further out from transplant. They tried to use the RICET biomarker in this study, and it hasn't panned out as of this point in terms of predicting tolerance moving forward, but there's ongoing data. There is interest, and I'll just briefly mention, in regulatory T cells being generated for infusion into patients, just like the Japanese study, and also in living donor liver transplantation. These are 2 studies of donor allergen reactive Tregs. I did want to kind of finish with a push for biomarkers of rejection. This has been a big interest of mine in terms of driving minimization of immunosuppression in a safer way, perhaps earlier or after transplant, but some of these can be particularly tested in tolerance studies, including microRNA signatures, proteoforms, mRNA in the blood, and donor-derived cell-free DNA, which could be important. So this is my last slide. So to consider patients for immunosuppression withdrawal, we generally have not included this in as a standard of care in clinical practice, but in considering this early after transplant, really need an immune modulatory environment to enhance the success rate. This still needs to be proven, though, on larger scale studies. These are being developed by the European groups, like the ONE study and also the Immune Tolerance Network in the United States. But a late withdrawal, it seems to be fairly safe. There are some biomarkers that are predictive, as long as patients are being monitored and have histology performed. But again, the clinical benefit is questionable. So these are my acknowledgements and funding, and really appreciate the opportunity to present today.
Thank you, Josh, for that wonderful inaugural address. Once again, I must thank you immensely for starting your day early on 7:30 to 8 in the morning, and from US, taking your time off and be kind enough to give this address. One of the important aspects of this is that such an address will probably stimulate the young researchers here in Indian subcontinent to take up certain studies in tolerance. My simple question to you is, we do a lot of living donor liver transplants. That's the way the structure is. Is an LDLT setup maybe in a different or a privileged advantage in doing the tolerance studies, because the donor and recipient both are under your control, and you can probably design your studies better? So maybe a comment from you, and then we can think over as how we can plan out better things and maybe collaborate in these things.
I 100% agree with you. And I listened to the last talk. We've seen the same thing, that I think there is an immunological advantage for especially biologically related LDLT. There's less rejection. There's less DSA formed. We published on that also. And also, as you mentioned, you can plan out immunomanipulations more easily, and especially donor-specific targeted therapies where you have access to donor cells, even in the blood. Some of these studies that I mentioned, the Artemis and Delta, we found, especially Artemis, we just asked the living donors to come back 3 years after the transplant and donate blood so that Tregs could be generated against their isolated B cells as stimulants. So I absolutely agree. I think the reason, I think understandably, it's going to be obviously geographic, where especially in India, where you're doing a much higher percentage. In the US, we are trying to grow living donor liver transplant, but it has not, for lots of reasons, hasn't boomed like around the world. And so I think while there's a lot of interest in that, it's a less common procedure here, although we're trying to grow it. But I certainly, again, Japan, Korea, where they're doing huge numbers, India, Turkey, where you have the ability to test this in larger numbers of living donor pairs, absolutely would be the right way to go. I think you'd have a higher chance of success, and also maybe it continues to promote living donor as the right approach, as opposed to deceased donor for the recipient.
Well, thanks. While Professor Levitsky is here online, anybody has any specific question, feel free to ask him in this short time, and we may benefit from his input.
Yeah, I have a question. So, the 2016 studies is probably the most radical study that has been published so far in terms of results of tolerance. But there hasn't been a follow-up study or more patients enrolled in the study. Why do you think that is?
You're talking about the Toto study, the Japanese study?
Yeah.
It's a good question. I mean, I think the group should publish their long-term data on those patients. They only have 1 year data. And so we really need to see how those do specifically, because they may lose tolerance over time. What I will say is that there have been attempts to, Sanchez-Fueo has developed I mentioned a protocol to generate regulatory T cells. And so there's a study going on right now in Europe to utilize those cells for tolerance. In the US, we tried to kind of direct towards the donor-specific approach, and the cells are very hard to generate in high numbers. And I think it's going back now to sort of autologous Tregs, where they're withdrawn from a patient by leukapheresis and expanded and then given back to the patient, instead of donor specific, because you can generate really high numbers. And so, these are very challenging studies to do. They take a long time. They sometimes fail because of manufacturing. And so actually where honestly the field is kind of going, from a cost perspective, from a perspective of difficulty with cell therapy, is going towards novel existing or novel immunosuppressive agents that may promote tolerance. For instance, like I mentioned, conversion to mTOR inhibitors, belatacept, abatacept, JAK inhibitors, they all, anti-CD40, they seem to suppress DSA, but may promote regulatory T cells. And so the idea might be a conversion to a drug that might be safer and easier to give a patient as a step towards withdrawal of immunosuppression. So it's sort of an evolving field, but you're right in the fact that that is really the only study that has given patients a Treg therapy and has had success, but again, a very small study. I think it's just complicated. So my sort of suggestion, if you go into this field, and wherever you are in India or wherever, that just think about the applicability and the cost to a larger population, and maybe there may be some more simplistic approaches that could be applied and tested that could be more feasible.
Yeah, thanks.
One last question from Sonal. I since he's raised his hand.
Yeah, thanks very much. There are certain studies on cell-free products such as exosomes being utilized in very limited situations. I mean, do you have any comments about that, about exosomes from, say, conditioned MSCs? I mean, of course, the obvious question about whether how often you need to give them and how much is remains. But do you think that there's does that have legs in sort of solid organ transplantation?
Has not reached the clinical space yet, to my knowledge, at least in liver transplantation. There definitely is interest in alternative therapies, as you mentioned, exosomes, nanoparticles, delivering drugs directly to the liver to reduce toxicity. There's also interest in mesenchymal stem cells. The Pittsburgh group had a really nice preliminary study on tolerogenic dendritic cell infusions. So there are other different approaches that are being looked at. I'm not aware of the exosome approach in clinical studies being tested yet, but thanks for that comment.
Thank you very much, Professor Levitsky. It was wonderful having you. Much obliged, and keeping the theme of this tolerance on the